Hello, Assalamu alaikum. It's my honor to me, in the name of Iraqi Pen Society, to welcome all the attendants in this Zoom. And first, we would like to give thanks to all people which support this lectures, especially Al Saad company for ultrasound, and the speakers, Dr. Sabah Al-Ubaidi and Dr. Sushta from India, from Kolkata. And I would like to thank all the people who are attend and listening to this nice talk. Our subject today is about knee joint. Knee joint is very important, big joint and the chief joint in the body. And we are, as a pain specialist, all days, every day, we are meeting cases with a knee pain, and not all the cases are treated by surgery or arthroplasty. Many of them are well treated by pain management. So start with anatomy and sonoanatomy of the knee joint, and it will be introduced by Dr. Sabah Al-Ubaidi. She has a PhD in sonar and radiology, and she is a 5BP pain medicine and musculoskeletal specialist. She is active in Iraqi Pain Society, and we would like to give her great thanks about her efforts in transmitting the update information and update techniques about pain management. So you can start, Dr. Sabah, inshallah.
Yes, okay, thank you, Doctor. Thank you. I would like to thank all doctors, joining doctors. I would like to thank Pain Society for you and other members of Pain. Also, very thanks to Al Saida Company of exclusive Samsung ultrasound in Iraq. Special thank for joining us, Dr. Sushbadas. She is the daughter of my sir, who is teaching me the pain management. So welcome all doctors, and I would like now to start my lecture, which is about the knee joint anatomy and then sonoanatomy. Then will be completed with Dr. Sushbadas about the intervention of knee joint. It is very important subject. So let's begin.
Yes, you can start.
Okay, is my slide visible?
Yes.
Okay, so now I begin with the anatomy of, just to compare it, with anatomy of the knee joint. As we know that the knee joint is the most important and big joint in the human body. And there are three bones contributing to the knee joint, which are the lower femur, the upper tibia, and the patella. The patella contain apex and base. Its base is directed upward, and its apex directed downward. And there's also another small bone, which is the fibula. It does not contribute directly to the knee joint, but it contains tendons and ligaments that contribute to the stability of the knee joint. So this regarding the bone anatomy. And if go to the posterior part, we have the condyle, the medial, this one, the medial and the lateral condyle, fibula and the tibia. So now, complete with ligament anatomy, just to increasing the size. Okay, if I put ligament now, so we should, for a proper examination of the knee joint, we should divide the knee joint into multiple compartments: anterior, posterior, medial, and lateral compartment. Now I teach on the right side. Okay, this is the right side. So we have anterior compartment, medial, lateral, and posterior compartment. In the anterior compartment, we have important bursa here. The bursa that is located just in front of the patella, this is called a pre-patellar bursa. pre-patellar bursa. And in the infrapatellar compartment, we have two important bursa. The superficial one, this is called the superficial infrapatellar bursa, and the deep one, it is called the deep infrapatellar bursa. Beneath it, there is structure that is fat, homogeneous fat. This is called, heterogeneous fat. In the suprapatellar part, it is homogeneous, while in the infrapatellar part, this fat is heterogeneous. This is called Hoffa's fat pad. This regarding the anterior part. Regarding the medial part, we go to the ligament anatomy. It represents the thickening of the knee joint capsule. So we have very important ligament that we should see on ultrasound for its stability and their structure. So we have layers here. The first layer, unfortunately, this 3D is not completely true. This first layer, it is the medial patellar retinaculum. So this, in truth, it is completed from here till here. So it is also cover the medial collateral ligament. This is the first layer, which is called the medial patellar retinaculum. Medial patellar retinaculum. It is continue from here toward here. And also we have important ligament that is continue from the patella toward the femur. This is called patellomedial, patellofemoral ligament. If we remove this one, which is the medial patellar retinaculum, we also unfortunately not found here. This is the ligament which is from the patella toward the upper part of the tibia. This is the patellotibial ligament. Imagine that this ligament here. Okay, so this is the first layer, which is the medial patellar retinaculum. Beneath it, this is the medial patellofemoral ligament and the patellotibial ligament. Another important ligament here, which is represent the second layer, is the medial collateral ligament that is extend from the medial femoral condyle toward the upper part of the medial tibia. This is the medial collateral ligament. It is also two layers. This layer, superficial layer, and the other layer is deep layer, which is continue with the meniscus, called meniscofemoral and meniscotibial ligament. And this is bursa related to it. So if we remove this and remove its bursa, also remove this ligament. So now we go to the lateral compartment of the knee joint. In the lateral compartment of the knee joint, we have also the lateral patellar retinaculum, which is also represent the first layer of the lateral part of the knee joint. It is also continue from here toward the lateral collateral ligament. But unfortunately, in this 3D anatomy, it is not 100% accurate. So imagine that this continue from here toward here. This is the lateral patellar retinaculum that represent the first layer. So if we hide this, the second layer is also continue from the patella toward the lateral part of the femur. This is the lateral patellofemoral ligament, lateral patellofemoral ligament, and bursa related to it. And also there is patellotibial ligament, patellotibial ligament. At the medial side, we said that the medial collateral ligament is continue from the femur toward the tibia. But here, the lateral collateral ligament, as we see here, it is continue from the femur toward the upper part of the fibula. So this is the lateral collateral ligament. So if I remove this with its related bursa, we have, if go posteriorly, we have important ligament here, which are connected to the upper part of fibula, anterior and posterior band of arcuate ligament. So this is anterior band and this posterior band of arcuate ligament. This ligament is not seen by ultrasound well. It is the anterolateral fibular ligament, but it is not important, so important. So if I remove the joint capsule now to go deeply within the joint, and removing bursa also with bone, now we go deep within the knee joint. So if we see here, this ligament that runs from two meniscus, this is called, just to remove this, this is called the transverse meniscal ligament. Sorry, just to see, this is transverse meniscal ligament. Also in this 3D, it is not true 100% because the anterior cruciate ligament, which is this, runs below it. So this is the transverse meniscal ligament through which the anterior cruciate ligament passes beneath it. This is the anterior cruciate ligament. It passes from the anterior part of the tibia and passes toward the medial part of the lateral femoral condyle. This is the anterior cruciate ligament, which is very important ligament. If we go posteriorly, so this most important ligament here is on thick and fibrous appear on the ultrasound. This is the oblique popliteal ligament, this one, thickest one, the oblique popliteal ligament. So if you're removing the joint capsule also, what we can see here, this is the posterior cruciate ligament, which is also important ligament to be seen. This is run from the posterior part of the tibia and runs toward the lateral part of the medial femoral condyle. It is attached to the lateral part of the medial femoral condyle. It passes between two important ligaments, anterior and posterior band. This is called meniscofemoral ligament that runs from the meniscus toward the femur. The anterior band called Humphreys type and the posterior type called Weisberg type. So this is posterior cruciate ligament, runs between these two ligaments, the anterior one and the posterior one. Anterior one called Humphreys one and the posterior one called Weisberg type. So if I hide this also, you see these are the meniscus, the medial and lateral meniscus. So now continue anteriorly with the muscular part. Go to the right side. Just decreasing, yes. So continue now with the muscle of the knee joints. If I put all muscle here. Okay. So as we said that we should divide the knee joint into anterior, medial, lateral, and posterior compartment. Regarding the anterior compartment, the largest muscle here and the tendon that is attached to the patella is called quadriceps tendon. Quadriceps tendon, this one. It comes from merging of four muscles. These muscles are vastus medialis, vastus lateralis, rectus femoris, and if we remove this, we can see also the vastus intermedius. So again, this is vastus medialis, this is vastus lateralis, and the above one is the rectus femoris. I hide this vastus medialis and this vastus lateralis. So below it, you can see the vastus intermedius. So if I remove the vastus intermedius, I can see this vastus intermedius, I can see small muscle, this one, that is attached to the shaft of the femur. This is called articularis geno muscle. Articularis geno muscle. So I remove this. This tendon or this muscle is continue downward in the infrapatellar compartment as patellar tendon. So this is the patellar tendon or patellar ligament. Sometimes we call it as patellar ligament. So this regarding the anterior part of the knee joint. Now we go to the medial side of the knee joint. In the medial side, we have at the upper tibia, we have three tendon insertion. This one, and this one. The first tendon that comes from the medial part of the thigh toward the upper part of the tibia, it is called sartorius. Sartorius. So I hide this. Another tendon that comes to the medial compartment, it is gracilis, also come from the medial part of the thigh. To insert here, this is what is called gracilis. And the third muscle that comes from the posterior part, if I see, you see, it comes from the posterior part to be inserted at the medial part of the upper tibia. This is called semitendinosus. So all these three muscles, if you see here, all these three muscles are called pes and serenus tendon. Pes and serenus tendon. If I remove all these, there is important bursa just below it. So we should examine properly to avoid pes and serenus bursitis, and also to examine the tendon well to avoid mismatching or forgetting the tendinopathy of Bis and Serenius tendon. So this regarding the medial compartment. Now go to the lateral compartment. In the lateral compartment, the important muscle that is inserted into the upper part of the fibula, this is the long head of biceps femoris tendon. It comes from posterior to insert it into the lateral part. This is regarding the lateral part. Now go to the posterior compartment. So this is the right side. This is the right side. So I said that from the medial side, we have at the posterior side, we should divide into upper part and the lower part. So the upper part consists of the medial compartment that consists of the upper tendon. This is called semitendinosus, and below it is the semimembranosus tendon. And from the lateral side, we have the long head of biceps femoris tendon and the short head of biceps femoris. These are related to hamstring muscle. These are related to upper part of the knee joint. Regarding the lower part, we have two muscles origin here, which are medial meniscus muscle. This is medial meniscus, and this is the lateral meniscus muscle. If we see there is muscle running between the medial and lateral meniscus that coming from the lateral femoral condyle, just above it, to be inserted, if you see, to be inserted downward. This one. If I removing this, this muscle, this one, is come to insert it downward. So what is this muscle? This muscle, this is small one. This is called plantaris muscle. Sometimes this muscle can be cause pain, especially in foot player person, and during eversion of the foot, that can cause pain or sometimes rupture of this tendon. So if you see fluid collection between two medial and lateral meniscus head, you can approach that it is rupture of a plantaris muscle. There is also an important muscle here that run obliquely from the lateral condyle and comes to the medial side. This is called popliteus muscle, and we can also see by ultrasound. So this regarding the posterior part. Here there is some important thing to be said here. This is the left side. So this is the medial side, and this is the lateral side. There is between the semimembranosus and the medial head of gastrocnemius an important structure to be seen and to be seen during doing ultrasound examination, because the origin of Baker cyst can be run from this location between the semimembranosus and the medial head of gastrocnemius muscle. These are all regarding the muscle, bone, and ligament anatomy. Now we go to the nerve, which is important. So we have in the medial part and in the lateral part compartment. Unfortunately, the knee joint is supplied by many nerves. So doing ablation of the nerves that we can do ablation for it can be gives a failure rate of avoiding the knee pain, because sometimes we cannot do ablation for all nerves. So the most important for innervation of the medial side of the knee joint, we have contribution from the superior medial genicular nerve, which is just at the shaft of femur, and the inferior medial genicular nerve. And also we have, if you see at the sartorius in this side, in anterior part of the sartorius, there is important branch that is called infrapatellar branch of the main saphenous nerve. And also we have nerve to vastus medialis. So all these muscles are contribute to the innervation of the medial side of the knee joint. Regarding the lateral side, we have important superolateral genicular nerve just at the femur shaft. And also we have the recurrent fibular nerve just surrounding the fibula. If we are removing this, surrounding the fibula. This is the recurrent fibular nerve. And also we have nerve to vastus lateralis. In the posterior compartment, we have important nerve that is just at the angle of the long head of biceps. long head of biceps femoris and short head, this is the sciatic nerve, important nerve, that is divided into the medial side and lateral side, into common peroneal nerve and tibial nerve, common peroneal and tibial nerve. So these are regarding the nerve anatomy of the knee joint. These are the important anatomy. Now I should go to the short video about a practical session of ultrasound. We do it by recording because we are at night and so we can't do live, but inshallah in the future we're doing live ultrasound session. So now I stop sharing and share the video. So is my slide are visible? Dr. Khalid, if you can, or anyone, can you please say to me? Is my slide visible?
Yes, slides are visible, ma'am.
Yes, okay, thank you. So I now open the video. Of the knee joint, we should put pillow under the knee. And for proper examination, we should examine the knee joint and divide it into multiple compartments for anterior, medial, lateral, and posterior compartments. So now we begin with the anterior compartment of the knee joint. I put my probe longitudinally at the patella. So this is the longitudinal view just at the patella. So what we can see here, this is the patella, this is the echogenic line, which is the bone. Behind it, we can't see anything. It is shadow. This patella, and this is the femur. The tendon that is attached to the patella is called a quadriceps tendon. Quadriceps tendon. There is a slightly homogeneous hyperechoic tissue seen here. This is the suprapatellar fat pad. Suprapatellar fat pad. This is the anechoic linear part. It is called suprapatellar recess. Suprapatellar recess. Here is the prefemoral fat pad, and below it is the hypoechoic muscle called articularis geno muscle. So again, to see it more clearly, this is patella. This is the quadriceps tendon. Suprapatellar fat pad, suprapatellar recess, prefemoral fat pad, and articularis geno muscle. This is the articularis geno muscle. This will begin in the suprapatellar part. Suprapatellar part. But this suprapatellar recess, we can't inject by this longitudinal view. We can go to the short axis view to inject in the suprapatellar recess. So now put my probe axial short axis just above the knee joint to see the contribution of the quadriceps tendon. So as we know, the quadriceps tendon comes from union of three muscles, which are vastus medialis. This is vastus medialis. This is vastus lateralis. And in between is the vastus intermedius. To become this, the quadriceps tendon. So every muscle, all muscle become tendinous before the vastus medialis. So the last muscle to become tendinous in a quadriceps tendon is the vastus medialis. So continue from above, downward, downward. You see vastus medialis till now, it is muscular, not tendinous. But the vastus intermedius become tendinous, vastus lateralis start to become tendinous. Continue downward, downward, until it will become tendinous. So where to inject here? Because this volunteer not contain a fluid in the suprapatellar recess, so it is not appear very well. But this is the suprapatellar recess in the short axis view. So we can here inject PRP or steroid by put the needle, whether from medial to lateral or from lateral to medial, as in this. You see, from here or from here, in a plain technique. This is the suprapatellar recess in short axis view. So now continue with the patellar compartment by flexion of the knee joint. So I put my probe also longitudinally on the patella. This is the infrapatellar part. This is the patellar tendon. The bone that appears above this bone is the patella. And this is the down, is the tibia. Between them, there is patellar muscle. This is patellar muscle or patellar tendon. Just below it, this is the fat pad, which is called Hoffa's fat pad. You see, this fat pad is just different from the suprapatellar fat pad that is heterogeneous, not homogeneous, the superficial part, while the deep part is homogeneous. So again, this is the patellar tendon that extends from the patella toward the tibia. Below it is the Hoffa's fat pad, which is heterogeneous in the superficial part, and it is homogeneous in the deep part. There is another two important locations to see here, which are just below the patellar tendon here. This is the infrapatellar versa, but the deep part. We have infrapatellar versa, superficial and deep part. So the deep part we should see near the tibia. This is the infrapatellar versa, and this is the suprapatellar versa, but no fluid in it, so we can't see it very well. Here you should see suprapatellar versa, and here you should see the infrapatellar versa. And when there is a fluid collection here, it is called bursitis, and we can do injection here by PRP or steroid. Also, there is very important structure here. If I just increasing the depth. When I put my probe also longitudinally and measure the distance from the skin about 1.5 centimeter. 1.5 till now. So this is the location now of anterior cruciate ligaments. Anterior cruciate ligaments. And just in front of it, we can see a short axis view of hyperechoic ligament called transverse meniscal ligament. So you see again. This is the hypoechoic. This two parts of hypoechoic, it is called anterior cruciate ligament. Just in front of it, there is hyperechoic, short axis view of transverse meniscal ligaments. Transverse meniscal ligament. So this is again, this is anterior cruciate ligament. But we should measure the distance of 1.5 millimeter or 1.5 centimeter, because the depth of anterior cruciate ligament is at that. Because sometimes mistake can be occur because this Hoffa's fat part is heterogeneous, so appear like the anterior cruciate ligament. For that reason, we should measure the distance for 1.5 centimeter. This is regarding the anterior compartment. So now we examine the medial compartment of the knee joint. I just palpate the femur, and this is the tibia. So put my probe here. You see, the above bone is femur. This femur, and this is the tibia. Between the femur and the tibia, there will be medial meniscus. So this fibrocartilage that appear gray or hyperechoic in color, it is the medial meniscus. You see this medial meniscus not contain any cleft, so there is no tear at it. And it is also within its position, within the outline of the bone, so there is no extrusion. Here, what is important? We have important ligament here. As we know that the medial compartment of the knee joint is covered by the medial patellar retinaculum. So the first layer that appear here, this is the first layer, the hyperechoic line that continue above to reach the vastus medialis and converge within it. So it is the medial patellar retinaculum. Then second layer, it is the medial collateral ligament. In the medial collateral ligament, we have superficial and deep parts. So this is the superficial part that if continue downward, you see, it is continue above the genicular artery and the genicular nerve. So this is the continuation of superficial part of the medial collateral ligament. The deep part, it is attached to the meniscus. This is the deep part attached to meniscus. So this is the meniscofemoral ligament, and this is the meniscotibial ligament, which is the deepest part of the medial retinaculum, medial collateral ligament. So we say that in the medial compartment we have three layers. The first layer is the medial patellar retinaculum, which is continue above till reaching the vastus medialis. So you see this is the medial patellar retinaculum now merged with the vastus medialis muscle. This is the superficial layer. Second layer, which is also consists of superficial and deep part, is the medial collateral ligament. This is the superficial of medial collateral ligament, the hyperechoic line, which is continued downward just above the genicular artery and nerve. So this is the superficial medial collateral ligament. Then coming to the deep part, which is attachment of the meniscus with both of tibia and femur. So this is meniscofemoral because this is the femur up, and this is meniscotibial ligament because the tibia is below. Now come to the patellofemoral. So I palpate the patella and put my probe the right side toward the patella and then the other side toward the femur. So this ligament is called, the second layer, it is called patellofemoral ligament. Remain here superficial is the medial patellar retinaculum. So the first layer at all medial compartment is medial patellar retinaculum. The deepest layer here, this ligament that attach between the patella and the femur, it is the patellofemoral ligament. And the superficial is the medial patellar retinaculum. Now, put my right side fixed on the patella. Then the left side is funning toward the tibia. So this is the patella and this is the tibia. The ligament between them is the patellotibial ligament. And the superficial layer remain as we said, it is the medial patellar retinaculum. Another important structure here, when we examine the meniscus, medial meniscus, if you continue downward, you see there will be 3 tendons here. If you see, these are 3 tendons here. This first, this second, the hyperechoic, and this is the third tendon. These are called SGS. What meaning of SGS? S is sartorius, first muscle, then gracilis, then semitendinosus. Below this muscle, there is bursa called pes inserenius bursa. So, if we have bursitis here, we can see fluid collection at this side. But the most common than bursitis is the pes inserenius tendinopathy. SGS tendinopathy, meaning that there will be hypoechogenicity within the tendon itself. Another important also is the nerve. So at the same location for examination of the medial meniscus, continue downward on the shaft of the tibia. So you can see pulsating vessel here because it is very small vessel. If I make increasing depth and zoom, so there will be pulsating vessel here, this one, pulsating vessel. So just proximal to this vessel, which is nearest to the joint, is the inferior medial genicular nerve. Inferior medial genicular nerve. You can do ablation here, but not your probe is longitudinal. Make your probe short axis just to open the vessel like this. Okay, the side that is proximal to the vessel, this is the inferior medial genicular nerve. So we can do ablation here. Even if you do ablation of the artery, which is common to do ablation, it is terminal artery, small artery, but the complication here is aneurysm of genicular artery. Another important structure of the medial compartment is to see the superior medial genicular nerve. So as the same procedure, we go to the shaft of femur. You can see pulsating vessel here. This pulsating vessel here. So just distal to this genicular artery, nearest to the joint, this is the genicular nerve. Again, you go to the femur shaft. So this is pulsating vessel here. Just distal to it, because it is nearest to the joint. This is the genicular nerve. But also we can do ablation by the probe longitudinal. So we should go in the short axis view by opening the vessel. So now we opening the vessel, just distal to it, we can do ablation of superior medial genicular nerve. Another important nerve which contributes to the medial compartment is the infrapatellar nerve, which is a branch of saphenous nerve. How to go? By go to the adductor canal. So you should see the femoral artery just above the knee joint in the medial part. So this is the femoral artery, open color Doppler. This is the femoral artery. Just beside this femoral artery is the main saphenous nerve. What appear here muscle, this is sartorius muscle, and this is the gracilis muscle. So just beside this femoral artery is the main saphenous nerve. So I go again. This is the femoral artery. This beside it is the main saphenous nerve. So main saphenous nerve is continue with it. It continue till reaching between two muscles of gracilis and sartorius muscle. So you see it will be passed between them. And the branch that is continue anterior to the sartorius muscle, if you see this one, until reach this one, anterior to the sartorius muscle, this is the infrapatellar branch of the saphenous nerve. Infrapatellar branch of saphenous nerve. This is sartorius muscle, this is vastus medialis, and this is adductor longus muscle. So now we continue with the lateral compartment of the knee joint. So now what we examine here, I put my probe longitudinally on the both femur and tibia. Tibia comes anteriorly while tibula comes posteriorly. So what appear here, this is the femur because it is up, and this is the tibia. Between them, there will be lateral meniscus. This is lateral meniscus. Here, the important that the most superficial ligament here is the lateral patellar retinaculum. So here is superficial layer, lateral patellar retinaculum. Now continue. Just below it, this is the iliotibial band. Iliotibial band. If continue up, you see this iliotibial band. Very clear. This is iliotibial band. It comes to converge with the fascia lata. So this is the iliotibial band. Now downward, this is the lateral meniscus. Lateral meniscus, fibrocartilage, triangular, appear hyperechoic, and it's within its location, so it is not extruded and not contain any hypoechoic or anechoic line that represent tear. So this is healthy meniscus. What appear here, this is hypoechoic muscle. Hypoechoic muscle that appear at the condyle of femur. This is popliteus muscle. Popliteus muscle. You see, this is popliteus muscle. So put my probe on the Gerdy's tubercle of tibia. This is the Gerdy's tubercle of tibia and on femur. This is the view. You can see the lateral meniscus and the iliotibial band with the popliteus muscle. Now, if we put my probe on the fibula posteriorly, you see, this is the head of fibula. What appear here, this is the femur, and this is the fibula. And if appear bone here, this is the tibia. Okay, so what you can see here, this is important ligament here that connects the femur to the head of the fibula. This is the lateral collateral ligament, and remain the superficial layer is the lateral patellar retinaculum. We said in the medial and lateral compartment remain the superficial layer is the patellar retinaculum, whether it is medial or lateral. So here what you can see, this is the lateral collateral ligament, and just superior to it, superficial to it, is the lateral patellar retinaculum. If we go from this side, more posterior, you see there will be a tendon attached to the head of fibula. What is this tendon? It is the biceps femoris. Biceps femoris tendon. That is attached to the head of fibula. This is the head of fibula, and this is the tendon. This is the tendon that is called biceps femoris tendon. Just below this biceps femoris tendon, there is tough, thick ligament that is attached posteriorly to the fibula. This is arcuate ligament, lateral band of arcuate ligament. So you see again, if we go anteriorly to the fibula, from the femur to the fibula, you can see the superficial layer of lateral patellar retinaculum and the lateral collateral ligament. If we go more posterior, you can see a tendon attached. This is the biceps femoris tendon, and just below it, this is tough, thick ligament called arcuate ligament. What other important structure to see here is the superolateral genicular nerve. Superolateral genicular nerve. So at the same procedure, you go to the shaft. This is the shaft near the knee joint, okay, shaft of femur. So you can see pulsating vessel here. This is pulsating vessel, if you can see by increasing that. This is the most difficult nerve to diagnose or to see it. So here there will be pulsating vessel. Here there will be pulsating vessel. Just distal to it because the nerve always near to the joint. This is the superolateral genicular nerve. We can do ablation, but by short excision view, by opening the artery, and then do ablation in the short excision view with the radiofrequency ablation. You see, just distal to it. This is the superolateral genicular nerve. Now we examine the posterior compartment of the knee joint by putting the patient in a prone position. So what we can see posteriorly, what are the most important structure to be seen? I begin from the lateral part. So in the lateral part, we have two muscles. The superficial muscle is called long head of biceps. And the deep one, so this is the long head of biceps, and the deep one is the short head of biceps. If you go more distal, you see that the long head become tendinous and the short head become large. And if you go above, you see that the long head become large, and the short head become smaller in size. So the lateral part contain both short, which is superficial, long, which is superficial, and the short biceps femoris, which is deep. The superficial one is long head of biceps, and the deepest one is the short head of biceps. You can see just at its angle, there will be nerve, which is the largest nerve in the back of the leg. It is the sciatic nerve. This is the sciatic nerve. So if you continue downward, you see this nerve will be divided into two nerves, which are the common peroneal nerve laterally and the tibial nerve medially. Common peroneal nerve laterally and the tibial nerve medially. So if we continue to see the common peroneal nerve, you see, this is the common peroneal nerve, go to the superficial part. You see, this is come to the superficial part to appear as lateral sural cutaneous nerve. So this is the lateral sural cutaneous nerve. If we follow the tibial nerve, which is medially, you see, this is the medial nerve. If you follow this, you see, it will become to pass between two heads of gastrocnemius. You see, it is just pass above, then it passes between the two heads of gastrocnemius. This is the medial head of gastrocnemius, and this is the lateral head of gastrocnemius. So just follow again from this. You see, this is the tibial nerve. Then follow, become superficial, until it will be passed between the two gastrocnemius muscle. And if you see that the superficial one that goes here, this is the medial sural cutaneous nerve. So at the lateral part, we see two muscles, which are the superficial one is the long head and the short head of biceps femoris. And just at the angle is the sciatic nerve, which if go downward, it divides into the common peroneal laterally and the tibial nerve medially, which pass between the two gastrocnemius head muscle. So if we go to the middle part of the back of the knee joint, you can see these two muscles, medial and lateral head of gastrocnemius muscle. So now go to the medial part of the knee joint. This is the medial part of the knee joint. What you can see here, the superficial muscle here is the semitendinosus, and the deepest muscle here is the semimembranosus. If you go above, you see the semitendinosus become larger, and the semimembranosus becomes smaller. While if you go coming down, you see the semitendinosus become small and the semimembranosus become large. Here is the most important structure to come here, which is between the medial head of gastrocnemius and semitendinosus. Here arise from the joint is the Baker cyst. So we should the Baker cyst are the medial compartments between semitendinosus and the medial head of gastrocnemius. Continue, this is semitendinosus and this is semimembranosus. And you should also see below the semimembranosus if there will be bursitis, because semimembranosus tendon contain bursa below it. If we go more medial, you see, more medial, you can see this is semimembranosus, this is the gracilis, and this is the sartorius. Gracilis, and this is the sartorius. Gracilis and sartorius. Another most important structure here is the posterior cruciate ligament. So when I put my probe at the intercondylar area longitudinally, intercondylar area longitudinally. What you can see here, this is the articular cartilage of the condyle. Articular cartilage of the condyle. So I put my probe longitudinal here, and you can see even the meniscus here and the articular cartilage. If you go more medial from this position, just to decreasing the depth, you can see this posterior cruciate ligament, which lie between the anterior and the posterior meniscofemoral ligament. So put my probe longitudinally in the intercondylar region, then you go from this more medial. This is intercondylar region. Okay, then you go more medial. What you can see here on the medial side, this is the meniscus. This is the posterior cruciate ligament, which lies between the meniscofemoral anterior and the meniscofemoral posterior part. This is the hyaline cartilage of the femoral condyle. Go medial. This is the posterior cruciate ligament. And above it, if you see, this is the semitendinosus that come more medial. You can see also here from this position, the pes inserenius persa, just below this. This is from posterior side. Now, the most important part of the lecture is how to inject recesses and what are the approach for doing injection. So we have 3 approaches. The suprapatellar approach, by putting my probe longitudinally just on the patella. So you can see here, this is the suprapatellar recess. But by making your probe in the short axis, you can do injection here in the suprapatellar recess, either from lateral to medial or from medial to lateral. So this is first approach, suprapatellar recess. Another approach is the medial patellofemoral recess, especially for those with the dry osteoarthritis in which no fluid are found. So by put my probe in the short axis from the patella toward the femur. So this is the patellofemoral ligament, and you can do also injection here by this approach, either from medial to lateral or lateral to medial, but better to do from medial to lateral because it is nearest by. Another. Okay, so this is the recess between the patella and the femur. You can do injection at this recess. Third recess is by lateral sides, lateral patellofemoral. So put my probe on the femur and the patella. So you can do injection here from lateral to medial or medial to lateral. This is the recess between the patella and the femur. The most important also is to examine the undersurface of the patellar cartilage, especially for patellofemoral ligaments. You can also able to examine the cartilage below the patella. So this cartilage that appear, this is the patellar cartilage, just above the patella. And above it is the patellofemoral ligament. Thank you for listening, and I wish my lecture will be light-hearted and not annoying you. And I wish the benefit for all my colleague doctors. So, Dr. Khalid, if you are found. Dr. Khalid.
Thank you. Yes. Thank you very much.
Thank you, Doctor.
Thank you for this nice lecture and this nice information. It's really a delicate ultrasound anatomy. And again, we are welcome for Dr. Sushta. She will introduce, give a lecture about pain management for knee pain. Hello, Dr. Sushta. Sushba. Hi,
A
Dr.
very good
Sushba.
evening.
Good
Very good evening.
Hi. I am Dr. Khaled. I was in the Radia Pain
Hello,
Clinic
sir.
since 12 years ago. And
Okay.
you was small, I think, before that time. Send my greeting for your father, Mr. Daz.
I will.
And maybe you will
Thank you,
find my
sir.
signature in one of the comments in the Radia Pain Clinic. I
Yes,
was
sir.
there making training at the same time where Kantik Babu was there. He was making training
Okay,
also.
sir.
You know
Yes,
Kantik
correct.
Babu. He still is
Yes, I
a
do.
close friend of your father. Okay,
I do.
we are it's an honor to introduce you for Iraqi Pain Society and to others, colleagues. And we would like to hear nice your experiments. And of course, you will collect both your expert and your father experts, skills. So you can start now. And
Okay, sir.
thank you again.
Thank you, sir. Thank you. Are my slides visible?
Yes, your slides are visible.
Okay. So today I'll be talking about radio frequency ablation for chronic knee joint pain. So for chronic knee joint pain, chronic pain basically when the symptoms are continuing more than 3 to 6 months, then it would be called as chronic in nature. And in those cases, we have to assess mainly for osteoarthritis of knee. We are doing procedures and like Dr. Saba had already mentioned, there are separate approaches and then there are separate pathologies which lead to knee pain. But today, mostly we will be focusing on the osteoarthritis, the different grades of osteoarthritis. So the early grades of osteoarthritis, we can go for the different intra-articular approaches for the knee injection. In the later stages, not much later. So grade 4, later grade 3 and grade 4, these two stages, mostly patients should be encouraged for total knee replacement. But in case when total knee replacement is not possible or not feasible for the patient, we can go for the different approaches where we give intra-articular injection. And mostly, if it is later of late grade 3 and grade 4, and if the cartilage plate between the bones of the knee joint, if that cartilage plate is already degraded, then we can go for this radio frequency ablation of the nerves. So basically what we are doing is we are cutting the pain signals that is being generated from the knee joint, and the signals are taken to the brain. So we are doing a thermal ablation on the particular nerve so that the pain signals are not transmitted and the patient feels no pain. So what is radio frequency ablation? So radio frequency ablation is basically it is an emerging treatment and it is becoming more and more popular these days. It produces thermal energy, and what we do is we stop the pain signal transmission. It helps giving pain relief to patients in cases of osteoarthritis. It can be used as an alternative to surgery, like I have already mentioned. If the patient wants to avoid surgery, or whether if the patient is not like fit enough or suitable for surgery, we can try this as an alternative. So osteoarthritis knee is fairly common in the elderly population. And amongst the general population, around 28% have symptomatic osteoarthritis knee. And in advanced stages, like I said, in cases of grade 4 osteoarthritis, mostly the total knee replacement is the only choice that is left with the patient. So what we do is RFA, we started with a conventional RFA, and now with time we have the RFA, the radio frequency ablation has improved. There are new advances, and there is cooled radio frequency, which helps create a larger lesion on the nerve. And therefore, if larger lesion is created, then it gives a better chance of pain relief. So here we discuss a case of a 72-year-old male with bilateral knee osteoarthritis, grade 4. Grade 4 is where there is very minimal or absolutely no joint space left, or there is no cartilage plate left between the two bones, the tibia and the femur. There will be a lot of irregularities within the surface of the bones, and large osteophytes can be seen. Okay. And conventional RFA of the genicular nerve is already been done. He has a long history of cerebrovascular accident in 2018, and is unwilling to proceed for TKR, total knee replacement. So this is particularly an ideal case where we can give radiofrequency ablation. So after the preliminary investigations and after taking a proper informed and written consent, the diagnostic genicular nerve block is first done, and then once it has given more than 80% pain relief, we went for cooled RFA. Cooled RFA of the superomedial, superolateral, and infromedial genicular nerve, and that almost led to like immediate pain relief and almost complete pain relief. So radiofrequency ablation, it has been almost 50 years that this technique has come up, and more it is becoming popular with the new advances. So first it was tried with back pain for lumbar medial branch block for the facet joint pain. Then in the 90s, sacroiliac joint pain was treated with radiofrequency ablation. Later in 2008, much later, so it was used to treat chronic pain, knee pain. And now, these days, we are seeing its varied uses on hip and shoulder pain as well. So basically, I want to emphasize on the fact that if there is any large joint which is causing the pain, which is causing the chronic pain, we can easily go for radiofrequency ablation, and it is seen to give good results if we are using cooled radiofrequency in these cases. So radiofrequency, how does it work? It causes disruption of the pain signals and by causing a thermal lesion. And how to locate the nerves? The nerves can be located easily by using the ultrasound, and then we can also use the fluoroscopy to find out the nerves. Fluoroscopy basically to anatomically locate the bone and then placing the probe, the radiofrequency probe on it. So I would like to emphasize on the fact that ultrasound gives a better visualization of vessels, blood vessels, and it helps in better visualization of the nerves. And, still, if we are looking for the axial spine, it is seen that it is better to use the fluoroscopy and as well as ultrasound if we want to increase the accuracy. So for large joints, if you do not have a X-ray machine or a fluoroscopy machine, then it is okay. We can safely go ahead with ultrasound. We are usually very happy with the results. In case of spine, in our institute, what we try to do is we try to combine fluoroscopy along with ultrasound. And after causing this heating of the surrounding tissue, ionic generation occurs, and that ultimately leads to the destruction of the nerve fibers. That ultimately leads to stoppage of the pain signals. The duration of pain relief is temporary. That is the unfortunate bit. varies from around 6 months, 3 to 12 months mostly, depending on the patient. Sometimes if surgery is when it is absolutely not possible, we can keep repeating radio frequency, but then we have to measure pros and cons and then go ahead and take the decision of radio frequency. So there are, I have been speaking that we started with conventional radio frequency ablation, and now different types have come up, cooled radio frequency ablation and bipolar radio frequency ablation. So what is conventional radio frequency ablation? Conventional radio frequency ablation, there is it is a monopolar probe, and there we produce a thermal lesion, and here in case of knee, I will be focusing more on the knee joint. So what we do is we usually take a 10 centimeter needle, and then the exposed tip is around 10 millimeter, and the needle which is used is 22 gauge needle. Sometimes we can also use an 18 gauge needle or a 20 gauge needle. And what we do is we give this radio frequency, this cycle of 90 seconds, and we repeat it once more. So we give 2 cycles of 90 seconds each, using a 10 centimeter length needle, 10 millimeter exposed tip, and 22 gauge. In case of cooled RFA, what happens is there is a circulating fluid, circulating saline, which is present around the probe to create large size lesion. It is larger than the conventional. Okay, so here the length of the needle is almost the same. It is around 10 centimeter length. But say suppose for a moderate built patient, we use a 10 centimeter needle. But in case if we have a lean and thin patient, we can also go for 7.5 centimeter needle length, which is also available. And then there is the exposed tip is 4 millimeter in size, and the needle gauge that we use is 17 gauge. And here one cycle is enough, one cycle of 150 seconds. Okay. Then there is bipolar radio frequency ablation. Here, what we do is 1 centimeter apart, we put 2 probes, and it creates a dumbbell-shaped lesion. So, pulsed radio frequency ablation, it was introduced in the late 1990s, and the technique it produces pulses of 45 volt and lasting for 20 milliseconds at a maximum tissue temperature of 42 degrees. And where do we use pulse radio frequency? Pulse radio frequency is mainly used where there is mixed nerve. So mixed nerve as in sensory and motor part is involved there. It gives pulse radio frequency can be used. But it is not it does not have such good results in case of large joints, especially the knee joint. So we do not prefer pulse radio frequency in these cases. Then what is the importance of radio frequency ablation? So why do we have to go for radio frequency ablation? So simple thing, if a patient wants to avoid all the pain of the surgery, then if like it is a good intervention when medicines have failed, and you can go ahead without the surgery, okay? And it reduces the opioid intake or the medicine intake for these patients. Then this is the same thing once again. What are the advantages of cooled radio frequency over conventional radio frequency? So basically, the cooled radio frequency gives a larger size lesion compared to the conventional radio frequency. So what happens is our chances of success improves. So what happens is this in radio frequency, when we are locating the nerve and then we are targeting the nerve, sometimes there are a lot of anomalies which are like changes in the patient to patient. The location of the genicular nerves widely vary. Okay, so like similarly, so we have seen that when we were doing the radio frequency using the fluoroscopy, and now when we are using ultrasound, ultrasound provides more precision. So why more precision is because we are locating the artery first, and then we are creating our lesion. So what happens is, this is a very important point, that due to the anatomical variation from not anomalies, if there are a lot of anatomical variation between different patients, then a larger size lesion will ensure that somehow or the other you have targeted the nerve, and that's how it gives better pain relief. So various studies have been done, and cooled radio frequency is being shown to give better results than conventional radio frequency. Now, conventionally, as ma'am has already mentioned, we have three targets for the radio frequency of the knee. So we have the superior medial genicular nerve on the medial side. Then there is superolateral genicular nerve on the lateral side. And then there is inferomedial genicular nerve again in the medial side. Now, we have seen that there are a lot of anatomical variations in the genicular nerves, and additionally, there are other few nerves, which gives supply to the knee joint. So basically, if these nerves are irritated, they also produce knee pain. So in case, if you are just conventionally blocking those three parts, it might not give you like a good result. But then unfortunately, again, for radio frequency, we have to target those three nerves only. But this is good to know for our knowledge. And also, if we are using a cooled radio frequency, or these days cryoablation is also present. So if we are doing a cooled radio frequency or cryoablation, we can look for these nerves, and if there is pain, we can target these nerves if we are able to locate it with the ultrasound. Mind it, all these nerves that I am about to mention, they are better seen, obviously, better seen or only seen with the ultrasound. Okay, so there is nerve to vastus intermedius, nerve to vastus lateralis giving the superolateral genicular nerve. And then there we have the supromedial genicular nerve, and then nerve to vastus medialis. Then we have this infrapatellar branch of the sciatic nerve, and we have this one, recurrent peroneal nerve, and we have these are the nerves which are producing supplying the knee joint. There is lateral retinacular nerve as well. So remember, nerve to vastus intermedius, nerve to vastus lateralis, nerve to vastus medialis, then recurrent peroneal nerve, which is a branch of common peroneal nerve, lateral retinacular nerve, branch of sciatic nerve supplying the lateral joint capsule. Then there is infrapatellar nerve, which is a branch of saphenous nerve. These are the other additional targets which you can include after you have included the three conventional targets. So this I have already mentioned. So where we want to avoid surgery, where patient is not getting adequate pain relief using a lot of medicines, including opioids, in those cases to reduce, mind it, so with different medicines, especially with opioids, there will be side effects as well. So if we are able to do a non-opioid approach, well and good. So we should be going for that only. And but the only thing is this radio frequency ablation, if you are using the ultrasound and then using the principles, it needs a longer learning curve, especially when we are using the ultrasound. But then the clinicians need to be properly trained for using it. So there are not too many guidelines regarding radio frequency ablations, unfortunately, till now. Some have been published. So I will be speaking mostly about the NICE guidelines and the Indian guidelines that we have published for radio frequency ablation. So the NICE guidelines mention that radio frequency denervation for osteoarthritic knee can be used if standard arrangements are in place, standard arrangements of clinical governance, consent and audit. Basically, if required, we can go for this radio frequency denervation. But the clinicians involved should have a specific training and experience in the procedure. Now, coming to the Indian guidelines regarding radiofrequency ablation that we have come up with is a few statements regarding it. So, in cases of in patients having chronic knee pain, genicular nerve radiofrequency ablation can be given, and it provides a significant amount of pain relief, mid to long-term functional improvement as well. So, if the pain is gone, a slight bit, your movement or the functional capacity of the patient increases, and it does not correct the deformity of the patient in later stages of osteoarthritis, but it definitely gives pain relief. So in chronic osteoarthritis knee, cooled RFA leads to a good amount of pain relief with decreased disability and improved quality of life. So cooled RFA creates bigger lesion, gives better results or better chances of pain relief, or the nerve ablation is much more successful, and that leads to decreased disability and improved quality of life. And then in patients with pain and dysfunction after the total knee arthroplasty, what we can do is RFA, which gives a good pain relief and improved performance. So after TKR also, we can go for the radio frequency. And then in patients with chronic osteoarthritis knee, cooled radiofrequency is a safe and effective method to intra-articular injections for improving long-term pain, physical function of the patient, and quality of life of the patient. So that brings me to the end of the lecture today. Thank you.
Thank you, Dr. Sushma, for your nice presentation and nice information about your lecture. So if anyone can have please a question, you can ask in the chat box or you can raise your hand.
Thank you very much, Dr. Sushma. It is nice talk, and we get so benefit from that. We are waiting for any comments, any question. Sorry, I am in a busy place, so a lot of voice. Any question? Any for both colleagues?
Dr. Khalid, I want to ask you, because we are in Iraq nowadays, we use RF intra-articular joint, but this is not recommended in guidelines. But
Yes,
a lot of doctors they use that. So I want to ask
yeah.
Dr. Sushba about that also.
Yes, I think before 12 years in Calcutta, I saw Dr. Daz use it intra-articularly. I don't know the cause or how it is the effect or what is the physiological effect. So, Dr. Sushma, can we told us about the use of intra-articular radiofrequency intra-articular?
Sir, if I'm very honest with you, I have started my pain journey locating the separate nerves. So I have my experience in intra-articular injection is very less. I haven't seen at all. Mostly, if as Dr. Sabha will also agree with us, we have been locating the nerves, these three nerves, and at the max, what we can do is combine fluoroscopy along with the ultrasound. So hardly any these days we are doing it intra-articular. I haven't observed any. And like I have mentioned, if the patient has any medial or lateral joint, say suppose if the patient has more pain on the medial side, we will be additionally targeting the other nerves supplying the medial side and separately the lateral side. Otherwise, those three nerves are the ones that we are ablating mostly.
Yes.
Thank you.
Because the guideline not mentioned that.
Yes. Thank you very much. Yes, of course. There is no guideline. There is no evidence based about the use of intra-articular radiofrequency. And I think ablation of nerve by ultrasound guided radio frequency calling is much enough. And my question to Dr. Sushba, why it is the effect is just a few months, 2 to 4 or 6 months? Why it is limited? And it is the same for pulse and thermal radio frequency. Is pulse I think is less.
So what happens is the nerve regrows back, as we know that the nerve it causes secondary lesions the radio frequency causes secondary lesion in the nerve, and then eventually by 6 months it comes back. When we are doing a conventional radio frequency ablation, it causes thermal lesions, and the cooled RF, it produces larger lesions. In case of pulsed radio frequency, again, the lesion size is not that much, and the temperature, as we know, is much lesser than the conventional. So it does not give so much good result as it gives with pulse. I mean, with pulsed radio frequency, the results are not so much as in case of conventional radio frequency. So pulsed can be only used where there is mixed nerve supply. It gives better results in those cases where we want to preserve it. Otherwise, it's better to go for conventional. And if we get cooled radio frequency or cryo, that is very good.
Okay, we have
mainly because of the size of lesion.
We have one doctor asking, so allow him to talk. Yes, Dr. iPhone. You can speak now. Dr. iPhone, I make you can. Okay, so I give you now. You can't speak now, Dr. iPhone.
Thank you for this great informative webinar. My question is about, as we know, the osteoarthritis has many stages, from first to fifth stages of osteoarthritis. Question is, radio frequency is effective in which stage of the osteoarthritis?
Dr. Sushba, you understand him, or I can explain?
Yes, I did. Okay. I did. Okay. I think I understood. Okay. So basically, sir is asking at what stage should we go for radio frequency ablation. So there are, as we know, there are 4 grades of osteoarthritis: grade 1, grade 2, grade 3, and grade 4. So grade 1 and grade 2, if we see that there is substantial cartilage plate left between the 2 bones. So in those cases, if we are giving intra-articular injections using platelet-rich plasma, or if we are using a viscosupplementation, what it does, platelet-rich plasma, basically the regenerative therapies, not just PRP, prolotherapy has also been done. So it regrows the cartilage. So once it regrows the cartilage, especially good results with grade 1, grade 2, and early grade 3 arthritis, if we can reduce the friction between the bones, then we need not ablate. And obviously, with regenerative therapy, with regrowing the cartilage, it gives longer time or longer duration of pain relief. Okay. In later stages alone, like or not operable cases where the patient is having extreme pain for a long time, and then there is no cartilage left in later stages of grade 3 or grade 4. Grade 4 arthritis, if you have seen, it means that absolutely there is no joint space at all. So in those cases, if we are trying intra-articular regenerative therapy, the results are not great. So in those cases, we are confined to only radiofrequency ablation techniques. So ablation techniques where we are trying to block the nerve signals. So we are limited by the duration of pain relief that this radiofrequency ablation gives. But since we have no other option, we have to go for these. So I hope I answered your question. So later stages only we can go for radio frequency. Now, if you ask me, grade 1 and grade 2 also you can give radio frequency. Why not? But then it is not feasible. It is not feasible to keep repeating radio frequency. If you can keep the cartilage, if you can regrow the cartilage and take back the patient to their original physiological means, then that is better. So we go for intra-articular injections in cases, intra-articular regenerative therapy in early stages, and later stages we go for ablation techniques.
Okay, thank you, Dr.
Thank you,
Azmi.
Doctor. Okay, I understand you. Thank you very much.
There is another question, Dr. Sushba. What about the posterior knee pain? Does the 3-nerve ablation is manage the posterior knee pain, which are the superior medial, infero-medial, and superolateral? Does it manage the posterior knee pain?
If there is posterior knee pain, first evaluation is required. What is causing the posterior knee pain? If what happens mostly, it could be because of Baker's cyst. Now, Baker's cyst, if you see, it is basically because of the effusion which is collecting at the back. So we have to find out the cause, what is causing the pain. But in case if it is causing like posterior knee pain, and if there is if you have to take out the effusion, we can go about drainaging the effusion. But again, ablation techniques, I have been mentioning 2-3 times that we are limited to ablating these 3 nerves only. So our emphasis is on these 3 nerves. Along with it, we can additionally, the structures that I have told, theoretically, if we are able to locate those nerves, we can go for locating. There is unfortunately not much documentation separately mentioning posterior knee pain getting relief with the nerve ablation technique separately. But then obviously, if knee pain is there, and if we are suspecting any kind of osteoarthritis causing the pain, then we will be ablating these 3 nerves only.
Yes, I agree with you, doctor. I have a case with pain at back of knee, and it is related to the medial side of the ankle. So when examine it, it is related to plantaris muscle. It is just causing pain just at posterior. So we should know pain generator. Mostly it is not related to just the knee, because if knee pain can cause anterior, lateral, and medial. So maybe tendinopathy, maybe bursitis, and something like that. There is another question, Dr. Sushba, sorry for that, annoying you. The ablation, I say that ablation should be done at axial, not longitudinal view, as Dr. Gautam also said that. So someone asked why ablation do an axial, not longitudinal view. For my answering, it is to become the needle more to be in parallel with the nerve and to avoid the vascular injury. What you said about that?
Yeah. So basically, you're correct. Actually, if we are able to locate the nerves in a longitudinal axis, so what we do is first in the short axis we locate the nerve, and then longitudinal axis, and it is our assumption that the nerve lies along with the vessels. So if we are tracing the nerve along the longitudinal axis of the artery, then we are assuming that our nerve is also lying parallel to one another. So it will give a better lesioning.
Thank you, sir, doctor. There is another question. Are there any risk on the surrounding tissue from its method if it is repeated? If the RF repeated again for the same procedure?
So the size of the lesion that it produces doesn't usually have any side effects. But then there is something called deafferentiation pain while we are doing the procedure. So deafferentiation pain is basically abnormal signaling of the nerve after repeating the radio frequency. So we should take measures to avoid deafferentiation pain. Basically, it is neuropathic pain following nerve ablation techniques.
Yes, okay. So there is no limitation for repeating the RFA. But what is the time interval between the procedure should be done? Is there any limited time interval between the procedures? Time interval. Yes.
Nothing as such, but more than 6 months is the usual time that we would follow. There is, again, like more than 6 months we will be taking to repeat the procedure again.
Okay. So thank you, doctor. Anyone have a question? I put now the link of certificate. So everyone now present till the end of this webinar, he can take the certificate. Yes, you can speak, Dr. Khalid. Yes.
just 5 minutes to talk about regenerative medicine.
Yes, okay.
Because if you want to treat the joint, you treat the pain and treat the function also. Because all the joints with advanced OI will end with a limitation of activity, limitation of movement. So I use since 6 years lipogym, lipid-rich in stem cell. I can share this video. It is just 5-minute video. 5 minutes to show you.
Okay. Doctor, you can share?
Yes, just a minute.
Yes, okay.
Just a minute. Welcome. I'm sorry.
No problem.
Maybe I couldn't share it. I don't know what's the problem. But it is a video about lipogym, lipid-rich in stem cell.
Yes.
It harvested from the abdomen and make it manually, not need to centrifuge to get it, and
Yes.
get about 10 cc of lipid-rich in stem cell. And نعم. So
Yes, doctor.
I'm sorry about that. I'm
No,
sorry.
no problem, doctor.
What's the problem? I don't know. Microsoft share from
So,
documents.
doctor, you prefer to do a lipogenic bone marrow or bone marrow aspiration? Yes.
Yes. Maybe I have electronic problem.
Yes, no problem, sir. You can speak, just speak about that.
No, yes. PRP is not effective as lipogym because PRP contain a very limited number of growth factor. While lipogym, you can do it under local anesthesia without a 2-millimeter incision, just for the needle, harvesting from the abdomen, lipid in the abdomen, in the belly, and put in machine, like a manual machine, make it manually, and
Yes.
extract this lipogym in syringe. You will get a very nice substance, and pure substance contain lipogym, and inject in the knee. I did about 400, 600 cases. 400, 600 cases. I get about 75 or 70 to 80 percent result, good result for lipogym. If anyone of our colleague, Dr. Sabah, you hear me?
Yes, I hear you, doctor.
Yes. Any other colleague use lipogym in injection? I use it for mild and moderate OI changes.
Yes.
Because it is an advanced case, you must do total knee replacement.
Yes.
So anyone use lipogym? I make a training in Italy, in Europe. It is evidence-based in Europe, in Italy, in Germany, and many countries. Until now, it's give a very good result for pain and for functional activity also. And it's give a relief for a long time, more than 4 years. Better than injection hyaluronic acid, better than PRP.
But we should
It's so
know,
effective.
Dr. Khalid, we should know how to prepare that, by which machine. It is available machine at hospitals, or we should buy
Yes,
this machine?
yes, yes. It is simple kit. It is
Yes.
just simple kit.
Okay, so it is
Just
a high rich stem cells.
lipid rich in a stem cell. It is
Yes,
just
yes.
lipid rich in a stem cell.
You prefer more than bone marrow?
No, not bone marrow. It is lipid, lipogen.
Yes, yes, but I say to you, you prefer it، يعني أنت تفضلها عن الليبid، قصدي الليبid عن البون مارو؟
Yes, الليبيد أفضل لأنه الليبيد بكمية أكثر. It is the lipid contain a lot of stem cell, and it is easily to get it, and it is outpatient technique. No need. It is just local under local anesthesia.
Yes.
And you give both. You get some lipid from the patient. Patient will be happy. You get it from him or her, a lot of lipid, and inject in the same time after 5 minutes. When just prepare it, need 5 minutes to prepare it by extraction, by shaking this lipid in kit, special kit, simple kit, and a cheap kit also, and you inject again. In both knee, the injection is not more than 8 to 10 cc.
Yes, that's good. Very good.
And it's effective in 7 to 80%. With I don't with ablation, with ultrasound guide ablation, I think it will give a perfect result.
Yes, yes.
I'm not sure whether the others use it or not. I'm not sure.
I think only a few doctors use this. I know some doctor using bone marrow, not lipid. So please, doctor, if you know the site for training for this procedure, you can make with us.
Yes. I just I can share it with my colleague in this group.
Okay.
Because now I couldn't reach to it. So I'm sorry for the technical problem.
No problem.
I will send the video. I will send the video in the group.
We take experience from your talk.
Okay, thank you very much. Thank you for patience. Thanks for all. Thank you, Dr. Sushba. Thank you, Dr. Sabah.
Thank you very much.
This is very nice effort. Great thanks from Iraqi Pen Society. And good night for all.
Good night, sir. Good night, sir.
They have it?